Ding, ding. What is going on, you beautiful people? Welcome back. We were not here last Wednesday, but we are fortunately back today now that my internet is working at my new place, and we're up and running and making all the things happen. So, very excited to be back tonight. We're going to be talking about which medication that we currently have is the most effective, or which one is the best weight loss medication to use and utilize. So we'll dive into that in the greater detail. I'll give it like 30 more seconds to see if everyone else shows up and stuff like that. But I hope everybody is doing well and having a wonderful Wednesday night. We are supposed to get a whole pile of snow here in Calgary, Alberta. So that's always super exciting to wake up to, and the chaos that is the roads and everything else in between. But we are nonetheless looking forward to it because, well, it's good for the environment and good for, preventing droughts and fires and all that kind of jazz. So important that it happens, I suppose, but it makes life a little bit more challenging for the brief period. So anyways, enough of my rambling. Welcome back, everybody. I hope you're doing well on this Wednesday evening. We're back for another Wednesday Live and talking about all the things that are obesity medicine. And what we're talking about specifically for today is we're going to talk which medication is the best one. Which one should you go on and try to go on, or what have you? Is it Ozempic? Is it Wegovy? Is it Zepbound, Mounjaro? The list goes on and on as we have multiple medications that are coming to market, all very exciting and everything, but how does one decide? The real kicker of it all is that there really is no right or wrong, if you will. I mean, we can kind of break this up into a couple of different categories or ways, if you will. So first things first, if we were to just look at purely based on the data, so we just said comparing one study to another study to another study, and we just looked at the average outcomes that were achieved in each of those studies, well, based on that data, what we can say right now is that Zepbound or Mounjaro, or tirzepatide is the generic molecule that's inside of them, is the most effective agent. So it led to the greatest amount of weight loss with about 21% weight loss on average. So very, very effective. That's actually a pretty ridiculous and high amount. We are getting closer and closer to achieving what we achieved with bariatric surgeries with the use of these medications. So very, very cool result in that sense. The next big guy would probably be the Wegovy, Ozempic, or semaglutide. On average, we saw a weight loss of about 15%. So we got 21, now 15% on average. So it kind of is the second runner-up, if you will. And then everybody else is kind of crowding around near the 12 to 5%. Again, these ones are Saxenda, it's the phentermine and topiramate combination, it's Contrave, the bupropion and naltrexone combo. So it's all these other guys that kind of fall in this range of things. And depending on the study, depending on how intensive the intervention was, like more behavioral-based therapy, psychotherapy, and that sort of thing, it's ultimately going to affect the overall results that was seen. And so, with Saxenda, it could get up into that 12, 13% range of things. Contrave as well could get up to 8, past 10, maybe to 11%, depending on the study and the intensity of the treatment or interventions that were also provided. And then phentermine and the topiramate combinations and such like that, they're also seeing some pretty good results in that range. So I'm kind of just going to group all of them together and just say that they're kind of falling in that general specific range. Ultimately, though, the other aspect that we really need to look at to decide what is the best medication for the individual that's sitting in front of me. It's great that we have this data. It's great that I can look at it and see what kind of participants were in each of the studies, what were some of their characteristics, did they have diabetes, did they have X, Y, and Z going on? And I can kind of formulate and make some decisions around that. But I have to be able to look at the individual that's sitting in front of me and decide what is going to be the best for them, right? And so every single person out there, because we all have different variations in terms of our genetics and such like that, we're all going to respond a little bit differently. And what might be the right treatment for me might not be the right treatment for you. And so it's finding and balancing all of the different factors that make up you as an individual, not only your physiology and biology, but also the emotional, psychological, and all those other things that you deal with, in helping us to choose what is going to be the best and most effective option for helping you to manage your weight. And in some cases, we miss the mark, we try something, it doesn't work, and we need to go back to the drawing board and take a look at another agent. And that's totally okay. That's well within the realm of practicing medicine. It is a practice in some degrees and trying to find what is the best treatment option for you. And so it can be a little bit of trial and error to determine what that is. Sometimes it's, the mark is dependent on kind of the clinical experience and what things you're presenting with, but those things can change and we can get different outcomes and different experiences. So I guess to give you kind of some examples or what I would use to kind of determine maybe what is one option or why I would prefer an option for one person over another one, it's going to kind of depend on some of their comorbidities. So pretty straightforward. If someone has, say, prediabetes, PCOS, or just in general insulin resistance, blood sugar problems and stuff like that, well, then I might be leaning a lot more towards the GLP-1 receptor agonists that are going to have a much greater effect on overall insulin, blood sugar levels, and helping to manage those. So that would be more of those guys that I would start swinging towards and looking at to help support individuals that are struggling with this weight and with their blood sugars, because we're going to kind of hit two birds with one stone. In saying that, we could still use one of the other agents like Contrave or the phentermine and what have you. Again, depending on if they've got other things that are going on, maybe they don't want to give themselves an injection. The list could go on and on as to why we would choose one of those other agents. But it's not always, again, black and white, and kind of there's always this gray that we have to be mindful of. Now, swinging the other way, some of the factors and things that I would take into account to, say, go with Contrave would be looking at an individual's, what is their mental health, how are they doing from a psychological, emotional, mental well-being, and that sort of thing. If there's some underlying or underpinning depression, anxiety, mood disorder, something like that, then Contrave with bupropion and naltrexone, bupropion being an antidepressant medication, a smoking cessation aid, and that sort of thing, might be a better option. Similarly, if someone struggles with alcohol use disorder, well, then we might also look at the Contrave, where naltrexone has some evidence for helping to manage alcohol use disorder as well. So that would be kind of something that might swing or steer me that other way. That's the pretty cut and dry and straightforward aspects of just kind of some of the broader senses. Other things that I might look at, are they currently smoking? What are they kind of also struggling with things like ADHD? What was kind of the environment that they grew up in? A lot of other different factors and things will come out and play a role. And sometimes it's kind of, well, I don't really have a good answer as to which one will be the best. We could try any of the above, see what happens, and ultimately they might have great success, or they might not have very good success, and we ultimately, again, have to go back to the drawing board. Or they end up having pretty severe side effects. So lots of people who go on these GLP-1 medications sometimes can't tolerate them. So at that point in time, okay, we need to go back and either tweak and modify if we can, change the dosages, maybe go from, say, Ribelsis, the oral form of semaglutide, start there and then switch them over to the injectable, or start on Saxenda, get them used to it and tolerating it, and then again switch them over to Mounjaro, Ozempic, and what have you. There might be things there, or it might be just switching to an entirely different drug class if there was quite a significant intolerance to the original medication we tried them on. So the short and sweet of it is, overall, is there's no right answer. Overall, if we look at the data, yeah, we could say Mounjaro, then Wegovy, and even the guys that are coming down the pipeline, they're showing even better results right now in kind of phase 2 trials and such. And so those are going to be some other big game changers. And on paper, again, they're going to kind of take over as being the top dog. But we again need to look at what does the individual in front of me have going on, because it's not just about giving you the best drug on paper. It's about finding and individualizing the treatment for it to be the most effective for you in your particular situation. And so I've seen plenty of times where, people have just been kind of prescribed Ozempic or what have you, just because it's the hot topic or whatever. And they end up in my office and it's like, no, Ozempic's not the drug that I would have started with. I would have started with Contrave or another agent, going to give you the most effective and best results and ultimately the best outcomes overall. And so it does require that deeper dive. It's kind of one aspect that I think like about my practice, and even just getting into become more of an expert in this area. A lot of people will talk about drug classes and think drugs are, within a class. So like say ACE inhibitors, drugs that we use for blood pressure management. People think that all ACE inhibitors are the same. They do the same thing, have the same effects and that sort of thing. But with each drug, there's little nuances. Maybe one has a particular side effect. Maybe one has more effectiveness. Maybe one has an extra trial or two where there is some additional data. And so we need to kind of, as clinicians, be thinking of that and kind of diving into those nuances between to, again, figure out what is going to be the most ideal agent for the person that's in front of us. And I think that is one piece that kind of gets lost along the way. A couple of reasons for that would be, A, clinicians are super busy. It's hard to kind of dig and dive into what is going to be some of that nuanced information and such like that. As well, it's extremely hard to keep up with all the literature. And God knows I haven't been able to really dive into the literature in a really deep dive like I used to as of late. And so that's going to kind of hinder my ability to determine and pull out some of the nuances. I almost need to spend like an entire day, for example, like when Mounjaro was first kind of coming out here in Canada, I had to sit down and go front to back through all the literature, read up on kind of some of the phase 2 and even some of the animal models and stuff like that. What are some of the theoretical mechanisms? What are some of the things that I need to be thinking of? And that's able to provide more detail of what I'm going to be using this medication for. Now, for me to look at something like Mounjaro, it's pretty easy because I know the mechanisms, I know the different physiology that's kind of happening with these drugs and how they're working and such. And so I don't have to do a whole bunch of additional background reading. If I were to go, say, look at seizure medications, for example, I do nothing with epilepsy, seizures, neurology, and that sort of thing. Find it super fascinating, but I do not know the drugs. I do not know the mechanisms. I do not know the physiology. So before I can even dive into the literature to figure out what's the best drug for, say, someone who has epilepsy, I need to go all the way back and fully understand what is even epilepsy at that foundational level and kind of build it up from there to kind of develop my expertise in that area. It takes a long frickin' time. And that's why we ultimately get experts in certain areas and such. And I get to kind of come on a YouTube channel and talk about all these things because I have done the reading, the literature searches, and collected all the data in that regard. So that was a bit of a tangent, a bit of a rant there as to how I kind of go through the process and figuring out what is the best option for the individual in front of me. But yeah, there really is no true right or wrong or anything like that. Yeah, we might prescribe the GLP-1 receptor agonist or the GLP-1 GIP in the case of tirzepatide, just because on average they are more effective. And if we have a patient that's in front of us that we're not able to tease out any further nuances, then yeah, they might be our first go-to. If they work, fantastic. If they don't, then we can go back to the drawing board. It's great that we have options and other things that we can look at. Very important because it does open up a lot more doors and avenues and how we can really help our patients. And so it's not like all hope is being lost or anything like that. It's kind of just tweaking and modifying to try and figure out what's going to be the best for the person that's in front of us and kind of taking it from there. So that's that, I guess. I don't think I really have anything else to say on that. So hopefully that provided you a little bit of insight into what is the best medication or what is the best medication for you as an individual. Again, there's a lot of different nuances, and you certainly can go back and check out my previous videos where I go into detail about specific drugs and that sort of thing and kind of talk about some of the mechanisms there. And so kind of detailing as to which ones might be the best for you. In fact, I should actually go back and do a couple of videos on kind of what people I would use, say, Mounjaro or Ozempic or tirzepatide or what have you on, and which ones I would use Contrave on. It's actually a pretty good idea. How about that? Cool. So give me some new video ideas. But anyways, enough of my rambling and ranting on. I'm very tired and kind of all over the place, and my ADHD medications have definitely worn off. So I am kind of starting to spiral for the evening. But we will take all of the questions that you might have and talk about what are the best medications, and if you've got burning questions on other things with managing your weight and what have you, we can dive into it and go over it. And yeah, if there is any questions out there. So Judy is asking, hi, Dr. Dan, what is the price for Mounjaro in Alberta? And does it go up with dosage or does it stay the same? So great question, Jody. The price of Mounjaro in Alberta right now is sitting at about I think it's like $3.98 if you were to say pay out of pocket for it. So it's almost $400 per month. The nice thing about Mounjaro is that each of the dosages are on parity. So what that means is that you're going to pay exactly the same for 1 month of 5 milligrams of Mounjaro as you would for 1 month of 15 milligrams of Mounjaro. So there's no changes in the price. It's going to be $400 across the board, no matter what. That does kind of have the nice feature in the sense that, say, with Ozempic, right now we only have the 0.25 to 0.5 and the 1 milligram pens here in Canada. And so if someone was going to go up to the 2 milligram dose of Ozempic, well, now you need 2 of the 1 milligram pens to get a month's worth of medication. Each pen's about $250 or so. So you're looking at about a $500 bill. So Mounjaro is more expensive than semaglutide, Ozempic, and that sort of thing. The drug company did that intentionally because, well, you are getting the additional benefit and the premium that is coming with the medication being more effective, at least on paper, and some of the other post-study or post-trial analysis that they've done and comparing it to Ozempic and Wegovy. It definitely does show greater weight loss results and benefits, and also greater reductions in A1C. So you are paying a little bit more for that premium, and likely this is going to be kind of a rolling average, rolling something. Yeah, I'm struggling with word finding now. Kind of just the process that's going to happen as new drugs come to market. You're going to pay that premium because they're a little bit more effective. It will eventually, I think, reach a point where, it only goes so high because we have much better price controlling here in Canada, and most of the rest of the world does. It's just the US that's an absolute dumpster fire in that respect of things. No offense to the US. And so, yeah, there would be kind of obviously some stoppage and stuff like that would come on it. It would more than if it's going to be up higher in price, is going to depend on the molecules. And if we start getting into things like monoclonal antibody development and getting very specific receptor breakdown and stuff, then we can get into some very expensive drugs and how they're manufactured and the creation of them and such like that. But yeah, again, kind of a random tangent and such like that from Mounjaro. But yes, the short of it is about $400 a month. So Zephyr Anatoly, after years of unspecified diabetes, they say I am type 1. What would you suggest for stubborn weight? Good question. And unspecified diabetes, that's always really tough. And so there's type 1, type 2, which are kind of the two main and two most common forms of diabetes. But then there's like type 3C, type 3, type 7. I think there's a whole pile of different types, and they all have different presentations. There was even one, I had a case the other day of a patient who had called flat bush disease, but it's like a type 1, type 2 kind of swings back and forth. Very fascinating. Or diabetic ketoacidosis driven diabetes. Anyways, in terms of individuals and using or trying to find the right medications for managing their weight, it does get a little bit more complicated when it comes to type 1 diabetes. And if you're no longer producing insulin, largely because what a lot of people are concerned about is that if you're not producing insulin, there does increase or a much greater chance of developing diabetic ketoacidosis, which can very quickly turn into a very life-threatening condition. As well, we can get you tipping too far to the other side and ultimately having hypoglycemia, which again can be very life-threatening very quickly. So that's kind of one of the big complications with it. We do actually have some good data utilizing the GLP-1 receptor agonist in individuals that have type 1 diabetes. The GLP-1s haven't officially got the indication for it yet, and I'm not sure if they will or how hard they're actually pushing on it, but we have some good trials showing that we can safely use these medications for people that have a weight issue and type 1 diabetes, and can certainly support them in managing not only their blood sugars to some degree, but also their weight. Since they don't have a functioning pancreas or a pancreas that is producing insulin, there is limitations on how far we can push that blood sugar level down. Ultimately, they are still going to need to be on insulin, but their insulin requirements may go down over time. In terms of the weight side of it, it still has that appetite reducing effect of things and can drive and provide that, that management piece of things. So it can help you with the weight management side of it. I believe right now, Ozempic and Wegovy kind of have the best evidence. Interestingly, Mounjaro, I'll be curious when we get more data around it. So tirzepatide is that GLP-1 GIP component. So on the GLP-1 side, we have what it's doing is similar to what happens with Ozempic and Wegovy. But this GIP component, it has a very interesting mechanism of action. And when your blood sugar levels, like when our body naturally produces GIP, when your blood sugar levels are low, GIP will then stimulate a hormone called glucagon, which will bring your blood sugar levels up. But when GIP is at a higher level, and so your higher level and your blood sugar levels are elevated, it will help to ultimately bring your blood sugar levels down. And there's kind of a magical concert as to how all of these things kind of work together and intersect. But if it kind of has a bit of a protective mechanism in preventing you going low, well, it might even be a better option in comparison to Ozempic to use. Even still, Ozempic, we like using it in type 1 diabetes because essentially the mechanism that the GLP-1 medications work on in terms of lowering blood sugars, when your blood sugars normalize out, the whole mechanism shuts off. And so the chances of going low are considerably quite low unless you haven't properly adjusted insulin and that sort of thing. So that's kind of some of the data and information in that respect. Alternatively, you could certainly look at Contrave and utilizing those medications. So the other ones, the kind of more oral agents, phentermine and topiramate, as long as there's no contraindications or such like that. And again, depending on what kind of some of your underlying conditions and such might be, those could also be excellent options to potentially utilize in type 1 diabetes. So hope that answers your question. Judy says, thank you for that. Is there any news on the Ozempic shortage? And is Mounjaro experiencing any shortage? So, yeah, the news on the Ozempic shortage, last we heard was like last month. Was it last month? Maybe it was October. It's been a while now, but essentially we were told March of 2024, things are supposed to be resolved. As I've said multiple times, I'll believe it when I see it. You know, if they suddenly start correcting the shortages down in the States, then maybe I'll have some hope. But as of right now, I don't know, March is coming up pretty quick. And to suddenly have the shortage corrected and all that kind of stuff, it's really tough to say. However, in saying that, a lot of people are being switched to other agents such as Mounjaro or Trulicity and stuff like that. And so that's going to alleviate the number of people that are using Ozempic and ultimately may help and allow that shortage to get alleviated. But then Ozempic might not necessarily be needed by a whole bunch of people. So that's kind of the news in terms of the shortage. Mounjaro, is it shorted? It's not like it is a shortage. Like they've reported it to Health Canada and said it's a shortage. It is and it isn't. Like the drug is there. The drug is quote unquote available, at least from the information that I've been provided. But it's kind of, you know, when they have a pallet or two that shows up at the wholesaler, the wholesaler has everybody screaming at them and saying, we need this drug. And so they're then kind of just taking their time and allocating and just making sure that they preserve the stock that is available and don't let things get too out of hand. So we then run into the same issue that's happening with Ozempic and such. So they're trying to be more mindful of it in that sense. So it's kind of a shortage, at least like the drug, it keeps coming. It's in limited supplies, but there hasn't been any indication that it's like kaput altogether. So that's kind of the aspects and things to think about it from that sense. So it's kind of a shortage, not really a shortage. I'm not sure if that answers the question, but hopefully that helps. Zephyr, thank you for the analytical answer. My pleasure. Vincent, hi, Dr. Dan. If I've been on 2 milligrams of Ozempic per week for several months, what dose would you suggest starting on with Mounjaro if I were to switch? Good question, Vincent. So I actually did a video on this a little bit more in detail. Was it last week or the week before? But overall, the best practice is to go back to the lowest dose of Mounjaro and work your way up. I would definitely recommend that for any clinicians that don't have a lot of experience with it and what have you. So if your doctor is a little bit nervous about it, just starting back on Mounjaro 2.5 and again, titrating that dose up is going to be the safest and easiest option. However, if you're on the 2 milligrams, there's kind of a couple of things to keep into account. In general, 5 milligrams, you're probably going to do just fine with and switching over to. Again, this is starting you out at a little bit of a lower dose. Just in case you get side effects with Mounjaro, it's better you start lower and then again go up. So that's kind of one piece to keep in mind, is that you can keep it there and work our way up from that component of things. If you really didn't have any side effects with 2 milligrams, like getting your way up there, you tolerated it pretty well, you're doing good on the medication and such, you could probably get away with going to 7.5 milligrams once a week of Mounjaro. But again, this kind of runs into more risks of, there might be more side effects and issues in that sense. The problem with a lot of these drugs, since we're doing a once weekly injection, once you give that dose, well, you're kind of hooped because it's going to be there for a while. And so we want to be mindful of that if it's going to cause some side effects, it's going to take you out for a couple of days. And so trying to kind of balance that piece of it. Actually, no, until I get a lot more experience with Mounjaro and stuff, I wouldn't switch anybody from 2 milligrams of Wegovy to 10 milligrams of Mounjaro. Maybe if a patient was on like 2.4, so the Wegovy dose, maybe, but even then, I would still want to start lower and kind of work our way up. Better to be safe than sorry is kind of the good way to think about it. So hopefully that kind of provides you a bit of info. And check out my other video. I did a lot more education around it and some of the other suggestions. So BV says, would you recommend talking with my doctor to switch from Saxenda plus metformin to Ozempic plus metformin? How big will the benefit be? And thank you for all the info you provide. My pleasure. It's really tough to say exactly like what kind of benefit you're going to be able to squeeze out. If you've gotten some benefit on the drug, say you went on Saxenda and metformin, there's nothing wrong with that combination. Again, metformin's a great, fantastic medication, has a lot of really good benefit. It's not really a drug that we use for weight loss. There's some data that it can help, but I don't really prescribe it for weight loss. Definitely used for more blood sugar management of PCOS symptoms, that sort of thing. So there's that piece of it. I guess you could say, looking at the paper and the studies, if you were on Saxenda and say you lost 10%, that was kind of the average that we saw in the clinical trials. Cool. We then switch you to Ozempic and get you to the highest dose of 2 or 2.4 milligrams once per week. On average, people lost 15%. So you might be able to squeeze out another 5% in terms of weight loss. Very well possible. Sorry. I have multiple alarms to tell me when I need to start getting ready for bed. So it's very well possible that you could squeeze out like another 5%. but it's going to depend on, what other kind of lifestyle changes you've made, or what other ones that you might be able to engage in and start tweaking and stuff. And keeping in mind that we need to think about the sustainability of all of this, and making sure that it's something that you can do for the rest of your life. It's not just something that we engage in for a period and then go back to previous habits that got us to the original weight. It's got to be sustainable. And we also have to keep in mind that your body's going to be continually adapting and being cranky with you losing weight and cutting your calories and such like that. And so eventually biology can bite you back in the butt if you aren't mindful of that and kind of making sure you're getting protein, all that good stuff. So really impossible to give you a good answer, but based on the data and kind of that idea, that kind of can give you some perspective on it. If you've lost, 15% weight already on Saxenda and you've stalled out, I would say, or actually, if you've lost just more than 10% on Saxenda, how much more you're going to get with Ozempic, Wegovy, and even switching to Mounjaro. Again, pretty tough to say. When you're getting up into that higher range of things, more and more weight is going to be more challenging, even if we add on an additional agent. So, or switch you to a different agent. So, yeah, lots of factors. But I hope that helps. Jeremy, I'm paying $450 a month for Mounjaro. Is there any cheaper way? So Jeremy is saying he's paying $450 a month for Mounjaro. Is there any cheaper way? It depends on where you're at, province, and all that kind of stuff. In Alberta, at least, it should be, that $398. Maybe a little bit less if you're going to Costco or what have you. But even then, since it's not listed on the Alberta drug benefit list, it does have a bit of a higher markup at present. So $498 per month is kind of the average, or $398 per month, sorry. So that would be that piece to kind of, think about. And I guess the cheaper way would just be shopping around a little bit and finding another pharmacy, or find out where exactly all these fees and numbers are coming from your particular pharmacy, and if they're putting an additional upcharge on it, which they certainly could. So I'd be kind of looking into that. So Talit says, on the US side, no Mounjaro shortage, at least anecdotally. I'm on it, and so are 4 family members in different states at various dosages, and no one is having any issues getting it. Yeah, fantastic. So it's really anecdotally, and depends on the pharmacy and place that you're going to and stuff. I've heard different reports, and other people have said that it's shorted. So it's going to be variable. It's going to be dependent on the wholesaler. It's going to be dependent on, like here in Canada, how much, we buy or each province buys and that sort of thing. So a lot of factors are going to influence it and play a role. Those are all going to be things that are going to be taken into account in terms of whether a shortage occurs or not. Jeremy says, I'm taking 2 shots of 15 milligrams a week of Mounjaro and no side effects. 2 shots of 15 milligrams. Jesus. More power to you, I guess, but I certainly would not recommend that in any form or fashion. That is a hefty dose, and I would not be doing that. I'm glad you're doing okay, and that's a big dose. That's scary, to be quite honest. Talit says, based on the alarm sound, I'm pegging Dr. Dan as an Android user. Absolutely. Although my laptop is a Mac, I am definitely an Android cell phone user. I have not been able to forgive Apple ever since they did, was it the iPhone 4? They did the big update, and then it intentionally slowed down your phone so that you had to go and buy the next one. That is a grudge that I am just unwilling to let go of, and will never let go of. So love my Android. Samsung Galaxy S23 Plus or something. I don't know. All I know is it can do a whole pile of things that I do not utilize it nearly enough for. But I get it paid for via other work and stuff like that. So I'm going to take it all day long. Messenger of mischief. Since we have no Ozempic, what should I talk to my doctor about switching to which drug? So, yeah, I mean, I did another video on this one as well about which medications to switch to. I think it was 2-3 weeks ago again. In terms of the Ozempic shortage and such. So depending on the indication, depending on your drug plan, all of those sorts of things, those are going to be some of the biggest things that'll kind of be teased out. But if there's no Ozempic, looking at Mounjaro, if your drug plan covers it. If Mounjaro is not available, switching over to Trulicity or dulaglutide. So Trulicity is again a GLP-1 receptor agonist. It came out a little bit before Ozempic. It's very effective at diabetes management and helping to manage the blood sugar and stuff. The one big difference between Trulicity, I would say, compared to Ozempic, and at least kind of the theory behind it, is that Trulicity is a much bigger molecule. Well, it's bigger in terms of the GLP-1 and just how it's structured and that sort of thing. So it being bigger, it's less able to cross the blood-brain barrier. And so it's less able to get into that reward center, less able to get to the appetite centers and decrease that seeking and food wanting behavior. So it's not as effective from a weight management perspective. But since it's able to access the pancreas and liver and all that good stuff, it has quite a good effect within the body and still lowering blood sugars, but not as good in terms of the weight management piece. So those would be some of the guys that I'd be looking to switch over to. The other alternative might be Victoza Saxenda. Again, still pretty good results. It is once daily injections, so maybe not ideal there, but if we're scraping the bottom of the barrel, those guys certainly could be considered. So Talit, same thing, same here. S23 Ultra here. Awesome. Yeah, S23 Ultra, that's the one that I have. So definitely Android all the way. And Soshi, I'm in Mexico where you can obtain some meds without a prescription. What would you recommend for a weight loss of 10 to 15 pounds? That is like an impossible question for me to answer without assessing somebody and stuff like that. It kind of depends on what you're looking at. Are you looking at kind of a 10 to 15 pounds more cosmetically? Is it 10 to 15 pounds and is it actually going to provide you some kind of benefit in terms of health? 10 to 15 pounds isn't a heck of a lot of weight. So it's kind of, we need to piece out what exactly we're looking for and what exactly we're trying to do here and such. And what are going to be kind of the health benefits that are going to be teased out of it. So those are some things to think about. If it's the last 10 pounds that you're trying to lose, I can tell you trying to lose that 10 pounds is definitely overrated and not worth it. Because if you're stable and you haven't lost that 10 pounds, in order to lose that additional 10 pounds, you're going to have to make changes that probably you're not going to like. It's going to be either increasing your activity, decreasing your calories further. And is that ultimately going to be sustainable for you, right? If it's not something you can sustain for the rest of your life, well, then you're just going to gain the weight back. And so what exactly was the point, right? So, yeah, I can't just recommend which one for 10 to 15 pounds. There's so many other questions and stuff that we need to know. Cosmetically. So I'm not a supporter of using these medications from a cosmetic standpoint. If you're looking just to shred 10 to 15 pounds, I mean, kind of mitigating and managing dietary patterns and that sort of thing would be the way to go about it. As well, looking at why we're ultimately needing to lose this 10 or 15 pounds. Is it going to drastically change your life? Is it going to be this all-encompassing thing and you're going to be a completely different person? And on the day you die, are the people that you loved going to get up at the altar and say, you know, I just wish so-and-so would have lost 10 more pounds, or they were just 10 pounds too heavy? We really need to look at what exactly are we trying to do here? What exactly kind of life are we trying to live? And why are we trying to lose weight? And if the focus isn't health and just trying to be as healthy as you can be, and it's just to for whatever reason you think society wants you to be at a certain weight and such, then we need to kind of recheck what exactly we're doing all this for. So yeah, hope that helps. Cool beans, everybody. Yeah, you heard my alarm go off, so I'm going to go to bed now because I'm very tired and it's been a very long week. It's actually been a very long month, and I can't believe it's December 6th at this point. We are, 19 days away from Christmas? So holidays are coming, very exciting. I think one of my next lives, if not this week, probably the following week, we're going to do definitely a bit more of a dive into managing the holidays, some of the things to think about. Ultimately, it's more about just not overthinking it. And again, going back to everything that I talked about around health and why we're doing all of this and such. So we'll dive into those in a little bit more detail next week. Great question. I should have looked this up, but I cannot remember what the topic's going to be for next week. Nonetheless, we will be back next week, so be sure to tune in. Check out my channels at the official Dr. Dan. And if you are in the Alberta area, feel free to reach out and we can definitely chat about potential options to help and support you. And you can come visit me at my pharmacy and pharmacist-led obesity clinic down in Calgary, Alberta. So that is it, and that is all, everybody. Have a wonderful evening and wonderful weekend, and we'll see you next week.